name is James Erkson. I'm with PANO. Thank you so much for joining us. First, I just want to thank you all for the work that you do, and thank you so much for carving out the time to learn about health insurance with us today. I know your time is really precious, so we just really appreciate you being with us. I also know we have a great mix of organizations represented from across the state on today's call, and just wanted to offer, whether you're a current PANO member or not, that I'd be happy to set up a time to talk with anyone about how PANO resources could help your organization advance its mission. If you're interested, feel free to email me at james@pano.org. All right, let's get started with today's program. It's my pleasure to introduce today's presenter, Jessica Gallardini. Jessica brings 22 years of professional experience to JRG Advisors in the key management areas of finance, operations, new business development, and marketing. She leads the JRG team with a focused determination to achieve defined objectives in all areas of business. Jessica also manages the group purchasing programs and business operation of JRG's professional and trade association clients. And Jessica is the President and Chief Operating Officer of JRG. Jessica, I know our time is short, so I just want to end it there. You can elaborate on the introduction if you'd like, but I want to just turn it over to you and your team.
Great. Thank you so much, and welcome everyone, and thank you for making the time to join us today for this Member Benefit Spotlight. I always like to begin with a little bit of humor. The conversation about health insurance and the Affordable Care Act doesn't always lend itself to funny, but the photographs that were on the screen that you were staring at before we started, my photograph was taken before Obamacare, and so if you were looking at me now, you'd see me 15 pounds heavier with more grays in my hair. Craig, his photograph was taken after the ACA, and he lost all of his hair since that time. And I will reserve comment for Chuck only because he hasn't yet joined us. He'll be coming on our side of the fence here in a few moments. But again, welcome. Just a few housekeeping items. The presentation should run about 35 to 40 minutes. We want to leave ample time for your questions, which will be at the end of the presentation. The lines are muted so that we don't interfere with each other with background noise. So if you have a question at any time during the presentation, you can type it in at the question box. And please remember to hit send. We won't get your question unless you hit send, and we will answer all of the questions at the end of today's presentation. And a question that we always get, so you don't have to type it in, we do send the presentation to all participants, and we also will send to you all the questions and answers that we take care of at the end of today's presentation. So with that out of the way, just a brief background. JRG Advisors is a privately held company. We are a Pennsylvania-based company. Our ownership plus 30 of our professional staff represent over 40 years of professional experience. So we have been in the business of health insurance and employee benefits for a long time. We are a consulting firm and an agency and a broker. We do placement and consulting with health insurance, all the relating employee benefits, human resources, and business risk management. Our corporate offices are located in Wexford, Pennsylvania. That's just a few miles north of Pittsburgh. We also have offices in Lemoyne, Pennsylvania, and in Steubenville, Ohio. Our history in working with the Health Alliance for Nonprofits dates back to the early 1990s. We have been working for more than 25 years with many organizations like PANO, basically aggregating members so that we can leverage the buying power for things like insurance products and also deliver many efficiencies for the administration of insurance, employee services, payroll, things of that nature. The Health Alliance has been serving the nonprofit community since the mid-1990s, as I've mentioned. So we feel quite close with nonprofit organizations throughout Pennsylvania. I think it's always good right up front to answer the question of what's in it for me. The PANO partnership with JRG sponsoring the Health Alliance program It not only gives you access to dedicated customer service, but also access to a vetted and dedicated resource for the information that you desperately need to help you, whether you are a small organization or a very large nonprofit, depending on numbers of employees, help you with that very important decision, particularly now with the health insurance purchase, how you continue to fund that health insurance purchase and remain in compliance with all the new requirements from the law. So with that said, I just want to point those things out and let you know that that analysis and that representation is offered to you free. That is part of your membership benefit with the Pennsylvania Association for Nonprofits. So let's get started. Today's format will definitely aim to define what I'll call the relevant basics of the Affordable Care Act. I really want to focus on relevance and the basics to ensure that we leave you today with what you really need to know, and then give you that empowerment to work with us directly to untangle the many details that would be applicable to you based on what we determine is relevant and basic to your situation. We also want to, once we determine what may or may not be applicable to you, really simplify the new requirements and the new options that would be available to you in the world of health insurance and employee benefits. So let's get started with the Affordable Care Act, or referred to commonly as Obamacare. Obamacare basically, in a nutshell, dictates that health insurance must include defined minimum coverages, and they must meet affordability requirements, and it must be available to everyone. So if you want to just understand why is there this thing called the Affordable Care Act, it was really to make coverage available to everyone that would not deny insurability because of a healthcare condition and would not be unaffordable for people to purchase. That individual mandate was effective on January 1st, 2014, and in essence indicates that all men, women, and children must be insured. Employer groups with 100 or more full-time equivalent employees, and we'll talk a little bit later about full-time and equivalent employees, must comply with the pay or play rules starting this coming January, January 15. Pay or play simply means, are you paying a penalty for not offering affordable minimum coverage to your employees, or will you play, meaning you will offer that type of ACA compliant coverage. Employers with 50 to 99 full-time equivalent employees are also must be in compliance with pay or play, but not until January 1st, 2016. So there's a little bit of a delay for those of you that fit that category. For employers with 50 full-time equivalent employees, pay or play is the option, as I said earlier, to pay the penalty for not providing the health insurance that meets the minimum coverage and affordability requirements, or to play. And play simply means to sponsor a plan that would be considered ACA compliant. There is an analysis and a calculation tool that we use to help you determine if you have 50 or more full-time equivalent employees, and we will get into that in the next slide or two. After the calculation, I think it's really important to point out, once you know where you fit, whether you're under 50, between 50 to 99, or 100 or more, the real meaningful discussion will be had about your organization, particularly your objectives in terms of your workforce quality, the competitive factors that you face in attracting and retaining quality employees, the value that you perceive your employees are counting on you as an employer, the culture of your workforce, and the financial impact that you face of providing or not providing health insurance as a benefit to your employees. When we go through not only the calculation, but this type of deeper dive discussion with employers, we typically find that most employers in Pennsylvania choose to play. They do want to offer coverage to their employees. The real work then comes into what type of coverage and how do I make that affordable not only to the employees but to the employer budget as well. So what group are you in? The full-time equivalent calculation, you probably have heard this before or sat through many other presentations with the pay-or-play calculator tools. The first rule was that you would use the previous calendar year to calculate your full-time equivalent employees. This year, they did come out with the 2014 transition rule, which simply means for your 2015 calculation, you can use any of 6 consecutive months in this year of 2014. In essence, what you would be doing is tracking the first, the number of your employees that work 30 hours per week. These would be considered your full-time 30s. And then the total number of hours worked by all your other employees, we call those variable hour employees, up to 120 hours per week, and you divide that by 120. The total of the monthly figures then are divided by the number of months, in this case 6 months, and that will tell you how many full-time equivalent employees you have. So you could be an employer with 45 full-time employees, maybe 50 part-time employees. When you track the hours worked and do the math over that 6-month period, and I just used a calculation of 50 employees working 20 hours a week. With that math, you would be looking at having 78 full-time equivalent employees. So you may not think you have 50 full-time employees, but in the new world of the Affordable Care Act, when you calculate the hours worked of all of your part-time or variable time employees, now your equivalent employee number is 78. So you would be fitting the 50 to 99 employer category. Don't get too worried about that calculation. That's something that we do readily, often, and easily with you one-on-one. So moving right along, if you choose to pay the penalty and you have determined that you have 50 or more full-time equivalent employees, what are the penalties? Well, the penalties are defined under the IRS Code Section 4980H, and we have what we call the sledgehammer penalty, penalty A, or the tackhammer penalty, penalty B. In essence, to keep this very simple for today, if you choose to pay the penalty and not offer coverage to your full-time equivalent employees when you have 50 or more, you'd be looking anywhere from an estimated $2,000 to $3,000 per employee per year in terms of a penalty. And there are some transitions in there and the percentage of employees. Of course, in each employer situation, that can be very different and unique to you. But just the takeaway here, if you're not going to be offering insurance, there are penalties that you would be paying on behalf of those employees. When you choose to pay or to offer qualified insurance to your employees and you have 50 or more full-time equivalents, again, you must meet the definition of affordability and the minimum value requirements. Minimum value meaning the minimum coverage available to those employees. So affordability is defined as the employee's cost, that would be what they're paying in terms of premium share, for their own coverage, single coverage, not their spouse or dependents, that amount that they would contribute toward their premium cannot exceed 9.56% of their W-2 Box 1. That's the simplest way of looking at that. The minimum value is defined as an insurance term, the actuarial value of the benefit plan. So the benefit plan needs to be at least 60% coverage. In the new world of the ACA, that's commonly referred to as the bronze level plan. A bronze level plan is the new standard of minimum coverage that must be offered to all employees. So everyone needs to evidence that they have at least the bronze level coverage. It's important to note here, too, as just a point of reference, most employers in Pennsylvania are in the high 80 to 90% coverage actuarial value. So when you start comparing what your coverage is today or has been historically, most people are not accustomed to coverage at the 60% level. We also have quite a few of you on the call today that have fewer than 50 full-time equivalent employees. It's important to note that if you have fewer than 50 full-time equivalent employees, you are not required by the Affordable Care Act to sponsor a health insurance plan for your employees. If you do choose to offer and sponsor health insurance for your employees, which if you'll recall from earlier, I stated most employers do still want to offer some level of coverage to employees. If you have fewer than 50 and you do sponsor health insurance, you do not need to meet the minimum coverage and affordability criteria. That's basically because the Affordable Care Act doesn't require you to even offer that coverage. Most employers in Pennsylvania really do fall within the under 50, or what we call in our world the small group market. Insurance companies responded to the Affordable Care Act for small group employers with a number of things. First and foremost, when Obamacare first came out, small group employers weren't sure what was going to happen with their coverage. You'll recall, most of you, that grandfather renewals were offered. Those were offered in 2013 and early 14. In essence, that allowed the employer to continue with its current coverage, current benefits, and most importantly, its current rating methodology, and basically avoid ACA altogether for the period of time of that grandfather renewal. Now, with the end of 2014, mostly December 14, and then we have in some regions January 15 renewals, any employer group that was small that took a grandfather renewal is now being offered what we're calling the grandmother renewal. And again, the grandmother renewal essentially allows employers to again renew outside of the requirements of the Affordable Care Act and avoid the rating methodology that goes with that. And also, those rates for those renewals do not include the new premium taxes and different costs associated with the Affordable Care Act. I would suggest to you that a high percentage of small group employers did proceed with a grandfather renewal, and many will likely proceed with a grandmother renewal. Doesn't mean that hands down everyone should. I think it's important to understand your mix, your budget as an employer, your workforce, and look at the options in the ACA and outside of the ACA as a small group employer. I've mentioned the rating methodology a couple of times here. When you move to the Affordable Care Act programs, barring that there will be a great-grandmother option offered, we're chuckling here. I find that to be highly unlikely, but I can't guarantee that there wouldn't be. But let's presume that when your renewal comes up after 14 and 15, you will be looking at Affordable Care Act options, and you may be doing that already. The rate will be determined, or the premium cost will be determined based on your workforce, every employee's spouse and dependent child, looking at the age, tobacco use, and the geography of where the employee resides. So in essence, the 5-tier premium renewal that you may have been accustomed to all these years, where you have one family rate, a parent with child rate, an individual rate, that would all go away, and you will be looking at, for every single one of your employees, they each have their own unique rate determined for them based, again, on age, tobacco use, and geography. Workforce compensation and subsidy eligibility consideration, that's the next bullet point. I think that's important to mention here because as an employer group with fewer than 50 full-time equivalent employees, you do have the option to leave the world of offering or sponsoring a group health plan altogether. And again, you have to look at your workforce, your culture, the expectations. But you also, maybe even more importantly, need to look at with us what is the compensation, the annual income of your workforce, because an upside to the Affordable Care Act for individuals who qualify, they can receive subsidy for the cost of the insurance. So the insurance that's available to individuals who don't have coverage offered through an employer, they can purchase on an individual basis at the government's websites, us.gov, and they can achieve some subsidy for the premium cost. So it may be less expensive for some workforces to purchase insurance that way versus through the employer. And we do a lot of work with employer groups, including nonprofit organizations that have made that decision, and we will actually meet with every employee one-on-one and guide them through that process. If they're eligible for subsidy, maybe eligible for CHIP or Medicaid, or they're not eligible for subsidy, but they can buy the same products directly and privately. Okay, we've covered some of the basics rather quickly, and want to talk a little bit here about what is applicable to you and when. In essence, the important takeaways, the individual mandate was effective in January 14, and it applies essentially to everyone. So if you are not insured through an employer plan, or you're an employer that doesn't provide insurance to your employees, it's important to know that everybody needs to evidence participation in a health insurance plan, at least at the bronze level, with their tax return. So, if you are not providing insurance, or you're an individual that doesn't have it provided to you, you can purchase insurance on the public exchange. And if you are subsidy eligible, it makes perfect sense to do that, and we do help people with that. Or you can purchase the same plans, they are the same plans, privately, and that would just simply mean you would not be buying it on the exchange, you'd be buying it directly from the insurance companies. Employer groups that do the calculation and have 100 or more full-time equivalent employees, you have been required this year to be doing your calculation and your record keeping, and you are required starting January 1st to determine if you will pay the penalty or play and offer a group-sponsored plan for your employees. And again, the same applies to those employers with 50 to 99, but that would be effective January 1st, 2016. In either case, all employers with 50 or more, so whether you're in the category of 100 or more or 50 to 99, you have reporting and communications requirements that will be expected of you in 2016 that are based on the 2015 activity. So if you fit this category, I'm not going to go into all of the reporting and communication requirements today, but know that we know what they are. And if you fit that profile, it would be important for you to understand what that is, because you will be reporting on that in 16 based on January 1st this coming year and forward. And then all employers who sponsor a health plan, regardless of employee size, so you could be an employer of 2 people, you could be an employer of 2,002 people. There are many compliance requirements for reporting relative to reporting to the IRS, reporting documentation for the Department of Labor, new requirements under ERISA. So there are many things that if you're offering insurance that you have to supply to your employees by certain dates, and then for new hires as they're coming in. And again, we have those checklists and we have that information. I did not want to bore you with that in the basic detail today, but at least to point out to you what you need to be thinking about, what would be applicable to you. Those are things that you need to be looking at now. So now that we've gone through some of the basics that are relevant and some of the requirements, I just want to reiterate that as a member of PANO, you can reach out and take advantage of the Health Alliance for Nonprofits team so that we can work with you to determine your full-time equivalent employee count, or confirm if you've already gone through that exercise. It doesn't hurt to do it again. Provide analysis to you to help you decide if you should be paying penalties or playing, offering those benefits to your workforce. We can guide you to define and implement your compliance and record-keeping needs. We have tools to simplify the record-keeping. We have many standard documents that you can use to meet the compliance requirements and communication requirements, not only with your employees, but also with the various government enterprises that you need to report to. And obviously, to transition into the next part of our conversation, we would help you proceed if you're going to offer health insurance. Look at the options and the strategies. The option to offer health insurance, if it's determined that that is what you will need to do. One of the things that the Affordable Care Act has done it has created new opportunities, new ways of looking at insurance, new funding methodologies, things that you should be considering for your workforce, quite frankly, to not only continue to offer benefits to your employees if that's your choice, but to do so in a way that's most affordable and sustaining, not only for you, but for your employees as well. So let's take a look at some engaging health insurance solutions and strategies. Whether at renewal, if you're grandmothering or you did the grandfather, you're looking at ACA, or you're already an ACA compliant group, basically starting in December and forward, one of the things that most of you probably have or are already insured in is a fully insured health insurance plan. And that simply means that the insurance company is defining the benefits and defining the cost of your premium based on not only your group and the characteristics of your group, but that of the entire community pool. So you are not at risk as an employer for larger claims or unexpected utilization of the program, but you're basically at the mercy of what the insurance company tells you your premium will be at every renewal. Another area that's been around for a long, long time, but typically only made available to employer groups of at least 500 employees or more, is self-funding. With the Affordable Care Act, self-funding or variations of self-funding that minimize some of the risk sharing are a great option to at least consider, because it does get you outside of the Affordable Care Act taxes and coverage mandates. Therefore, you have more flexibility in defining your benefits. It also gives you the information and the data that you need about how your workforce is using benefits so that you can tweak benefits and coverage designs to make it more affordable and more conducive to the wellness and the objectives that you might have for your employees to gain as much as they can out of the health insurance plan. Self-funding, I mean, it surprises us in the industry, but it can be available to employers with as few as 10 employees. So if it's something that you've never looked at because you didn't have, hundreds of employees, it is something to learn more about. We're very well versed in that. And we can take you through very simple questions and analysis to determine if it's something that you should explore. Defined contribution is not a new concept, but it's one that I think lends itself very well when we start talking about private exchange, which we will do a little bit deeper of a dive on next. But defined contribution is simply when you, the employer, determine the dollar amount that you will make available to every employee to spend on their own coverage needs. So they may decide to spend the total contribution just on health insurance, or they may choose to spend that on health, dental, and vision. They may look at life insurance. So it's really getting to what the employee needs from you, the employer, on that menu of health plans and other coverages. This type of contribution strategy works hand in glove with the private exchange platform, again, that we're going to discuss in greater detail next. Other things to really think about at this renewal in particular, and then every renewal, quite frankly, forward, make sure you have the opportunity to do very well prepared for employee open enrollment meetings. There are changes in the benefits. There's changes in the funding. People have a lot of questions about subsidy eligibility and the Obamacare exchange. I think it's important that your employees know that you have taken the time to have professionals come in and answer those questions objectively for them. Many employers are also taking advantage of one-on-one enrollment. So depending on what you're offering, what your strategy is in terms of funding and cost sharing, that one-on-one enrollment with each employee can be very beneficial, not only to keep your enrollment where it needs to be, but it's a great reflection of you, the employer, and you really care about the workforce. You want to make sure they understand the cost, they understand the coverage, they're maximizing those benefits that you're making available to them, or maximizing the defined amount that you've made available to them to shop and purchase what they need individually. Another area of consideration at renewal should be voluntary and ancillary benefits. These are particularly important with the renewal and the types of plan designs going forward, as there are higher deductibles, more out-of-pocket expenses, more cost sharing. Even though the employee has the coverage, oftentimes they have expenses out of pocket before the coverage starts, and that may be something that they're not accustomed to. There are products that they can purchase that will help them, for lack of a better phrase, shoot the gap, so that some of those expenses that would be out of pocket, they can actually have covered with different insurance policies that make that available to them. And last but not least, if you haven't already talked about wellness strategies within your workforce, employee health management is really, really critical now and going forward, particularly if you're looking at sharing costs or going into a self-funding arrangement. Wellness can be absolutely measured and be impactful to make a difference to the overall cost of the program, and certainly the productivity and the health and well-being of the employees. Things like biometric screenings and the right type of ongoing health coaching and management of professional resources, these are things that are available to PANO members through the Health Alliance that can really set you apart within your communities and really have an impact on the employees, and then help you design the benefits that meet the needs of your employees. So they are getting the prescriptions that they need. They are getting the screenings, the mammograms, the colonoscopies, the wellness preventive care that maybe they don't take the time to do now, or they don't because they don't see the difference that it makes. You can really mitigate a health condition and longer-term high-cost expenses by going into a good employee health management system. And then certainly, there's always a lot of work that goes into the renewal, and I think once the renewal is decided upon and communicated, most people want to jump for joy, clap their hands, and throw it in the drawer and not talk about insurance again for another year. And really, that's definitely not the right way to go. And I think another benefit that PANO brings to you through the Health Alliance is the post-renewal work. We try to ease with you the administration that occurs. As you know, in the world of insurance, there's always the claim that's not paid, the doctor that's not found, the ID card that's missing, the changes that happen in your workforce, whether it's new hires or COBRA eligibility issues, on and on and on. That type of administration work is handled through the Health Alliance with you and your designated HR or company representation. And again, as we talked about earlier, that compliance reporting, record keeping, and communications that are required, those are the types of services post-renewal that you would expect through the Health Alliance to be accomplished with you. Employee service is another big thing. It's great to have the open enrollment, get everybody enrolled and set up, but throughout the year, employees need to know what's available, what preventive services are available to them. They need to know where to call if something isn't working or they have a question. So the Health Alliance actually has set up a toll-free number that's dedicated to PANO members who participate in that program. It's answered by licensed, qualified representatives. You'll remember earlier I said our group of people has over 40 years of experience here. Most of our service representatives have been with us no less than 8 years. So they work closely with the employees and even their dependents to solve any number of issues on any given day. And they get to know your business, your plan design, your employees, and can oftentimes alleviate the stress that just comes with having to go to the doctors or an ER visit and follow-up visits. And then stewardship of the strategy. There's a lot of strategy that goes into this renewal, as it did in your past renewal, I'm sure. And as the ACA continues to evolve and new products and services and funding arrangements are made available, coming up with understanding your strategy today means we need to have stewardship of that strategy. So where are we quarterly? Are we meeting the mark? Is something changed in your organization? Are you adding a lot of employees or changing the workforce complexion, or do you have a budget constraint that was unexpected? These are the types of things of stewardship so that when the next renewal comes around, we're not sitting down and trying to do all of that work plus working through the cost of the renewal and what the next year's plan should look like. So post-renewal is just as important, if not more so, in our minds as the decision at renewal. So let's take a deeper dive on public versus private exchange options. This seems to be a very relevant topic and a great option that many employers are looking at. The main types of exchanges today, the public exchange known as the marketplace, that's available to most people in the United States. There's also the SHOP, or the Small Business Health Options Program. That's also the marketplace that's available for small businesses. And then private exchanges, and those would be exchanges not made available at US, am I saying that correct, Craig? US.gov. Healthcare.gov, thank you. Private exchanges would be very much like the public exchanges, but not offered through the government, but privately from insurance companies and administrators. Just a little bit about public exchanges, and there it is, at www.healthcare.gov. That is what the state of Pennsylvania uses, and that is the federal exchange. Some, but not all, insurance companies offer plans on the exchange. All plans on the exchange will meet those essential health benefits, cover the pre-existing conditions, and offer preventative care that we talked about earlier. And what you'll see is there are plans that are defined by metal levels. So there's bronze, silver, gold, and platinum. If you'll remember earlier, we were talking about the minimum, the new standard of minimum coverage would be 60% coverage actuarial value, and that was defined as bronze. So as you move up the metal levels, obviously the benefits and increase, the out-of-pocket expenses would decrease, but the premium costs would also increase and move up the spectrum. The public exchange is designed to help a person determine if they're eligible for a subsidy or a lower monthly premium or reduced out-of-pocket expenses. It can also determine if a person's child is eligible for CHIP or eligible for Medicaid. CHIP and Medicaid are outside of the exchange, but they would, if you qualify for CHIP as a child or you qualify for Medicaid as just a person in general, those would be the least costly avenues for you to go. So how are subsidies determined? They're basically determined using the household size and the income of the household. So the subsidy or the lower monthly premium payment, it can be used on any one of the plans. So you can choose, once your subsidy is defined, you can choose to apply that to bronze, silver, gold, or platinum. Individuals can choose how much of the subsidy to use. Some people would also qualify for lower out-of-pocket costs. That would also be known as cost-sharing reductions. So based on their income compared to the poverty, federal poverty level, they may also see some cost-sharing on co-pays and deductibles and things of that nature. That type of cost-sharing can only be used on the silver level plan. So a person that would qualify for cost-sharing reductions would be buying the silver level plan to take advantage of that. And again, as I mentioned, that site will help you determine if you have eligibility for CHIP or for Medicaid. It's also important to say again that the health plans that are available on the exchange are the same as those available off the exchange. So if you don't want to buy through the government site, you don't want to supply the information, or you simply don't qualify for the subsidy, the same health plans that are available there are available for private purchase. I'm not going to spend a whole lot of time on SHOP because we haven't found that very many employers take advantage of the SHOP. I don't know that the longevity of SHOP will be successful, mostly because employers that are going to look at this route, there's already tax advantages for premium contributions that you can take advantage of, and the ability to have multiple plans or work with multiple insurance companies. It's something that is very difficult to administer on the public exchange. But with that said, SHOP is something that is available at healthcare.gov. It is for small businesses, and it does provide a tax credit for those that qualify. You can get up to a 50% tax credit, or for this audience of tax-exempt businesses, up to 35%. This would be for employers with 50 or fewer employees. So this would not be something that those of you that fit the 50 to 99 or 100 plus would qualify for. If you went on SHOP, 25 or fewer employees to get the tax credit, or 10 or fewer to get the full amount tax credit. You have to contribute at least 50% of the individual premium as the employer, and the average wage of the workforce needs to be under $50,000. You would pick one plan, and that's what your employees would have access to. As I mentioned, the future of SHOP would be that the employer would pick the metal level, and then the employees can pick whatever plan they want, or in other words, whatever insurance company plan they want within that metal design. Private exchanges. Again, we talked earlier about defined contribution. That lends itself really well to a private exchange. So you would define your budget amount, the amount that you would be willing to contribute toward the benefits that each of your employees are purchasing. That can help you budget for future years, thus certainly help you to control your costs. Your employees would select the benefits based on their own needs. So in essence, there would be multiple health plans, dental, vision, life, disability, all kinds of things that instead of you saying to each employee, here's the health insurance company and plan, and here's what you have for coverage, you can put a broad spectrum and a variety of plans on that exchange, and employees can pick and choose based on their own coverage needs and, quite frankly, their desire to maybe spend more in premium per month and have a lower deductible or out-of-pocket, or see somebody that would rather not have more to spend each month, but they can feel comfortable with a higher out-of-pocket deductible or co-insurance. The future of exchanges, this type of health insurance solution and strategy is really here to stay, and it's definitely the wave of the future. Experts in our industry and many large survey groups predict that over 65% of employers in the next 2 years will be operating on some sort of exchange platform with a defined contribution. The public exchange already has millions enrolled. Private exchanges, today, just about every insurance company has one, or they are building one, their own version of one. And then also what you will see in the future is the company exchanges that have multiple insurance company plans on that. So you might have a mixture of a Highmark and an Aetna on one exchange, so that your employees truly have even more options, not only on coverage, but maybe network or the type of insurance that they're looking for. So just in time, because my voice is, I think I need some water. In conclusion, the ACA certainly creates change for everyone. I want to make sure I leave you with, as a PANO member, that you do have access to a lot of information. Today was very basic and relevant, as we talked about, and certainly that professional guidance that you would need one-on-one is available to you. And I think it's important to stress that, because we want to help ensure that your health insurance and your employee benefits and the strategies are what work for you. They're the best for your workforce. At the same time, they're meeting the ACA reporting, coverage, and compliance requirements. So we would hope as a PANO member that you would access that information and guidance from the Health Alliance. So at this time, I will open the questions. And I will just reiterate as well, I have both Chuck Whitford and Craig Pritz that I introduced earlier with me. Chuck Whitford is a consultant with our company. He is our ACA compliance expert. He's supported by many other people who also do work in that, but he definitely heads up that area in our company. And Craig Pritz is a senior sales executive with our company, and his expertise and leadership is with our workforce that works specifically with individuals who are looking to purchase privately or publicly, and then small group employers that are weighing the options of a grandmother renewal or an ACA renewal. And he has great expertise in what would be available to employers in that category.
Okay, the first question. Many small nonprofits reimburse their employees for their personal health insurance. Under the new rules of the Affordable Care Act, are the reimbursements to the employees considered taxable income? If so, are they reported on the W-2 or 1099? And is there a standard ruling published in any location?
Well, it used to be, this is Chuck Whitford speaking, it used to be plans called employer payment plans, where an employer would give money to an employee to pay for individual premiums. And under the laws at the time, they could actually deduct that as a business expense. However, at the end of last year, the IRS made it very clear that these type of plans are illegal. They fly in the face of the market reforms of the Affordable Care Act. So you can't have a freestanding plan, qualified plan, and get a tax deduction from it from individuals' premiums. What you can do, however, is more traditionally increase their pay, have a payroll function, and allow for premium payment that way. But it has to be it's a separate situation now. It has changed. And yes, there are rulings from the IRS that are available and we can make available to you.
The next question. Do paid interns count as part-time employees, or is there a loophole to exclude them?
Well, let's see. An intern, as long as they're being paid, they are an employee. It's more about length of service and category, I think. So I guess it determines really how long the intern is going to be there. Seasonal employees are typically defined as 6 months or less. So I would go more on that guidance than anything that would be more specific to an intern per se. I don't think that categorize the employee workforce at that level.
We talked earlier, Chuck, when we were talking about the calculation of full-time equivalent, those that are full-time 30s versus everybody else that we labeled variable. So I would think that interns, seasonal, part-time people are in that variable
yes.
employee category, and they're part of the calculation of, as a total body of people, the hours worked per week up to 120 hours, and so on. Okay.
Exactly right.
Okay.
We have a few more questions, and then we'll wrap it up. The next question, my organization was not permitted to keep our old plan, grandfather, when we renewed in January 2014. I understood that those with renewals from January through March of this year did not have that option. Were we missed? Is there any way we can go back to what we had before our current ACA plan in 2015?
Well, the crux of the matter is that the law was taking effect January 1st, 2014, where every employer had to have an ACA compliant plan, needed to get one, and there hadn't been any changes in the law. The insurance companies, quite frankly, I believe were looking to try to extend the current terms so they could understand it better in the future. So there are a lot of early renewals being issued in August of the year for February 1. theory being that you renew December 1, and if you're eligible, and you can keep your plan. Other than that, you renewed the 1st of January. Then, as in the fall, there was a lot of fallout over if you like your plan, you can keep it. So the administration came out and said if each state, it's a state-by-state decision, they could allow renewing policies to be either non-ACA compliant or the new ACA compliant version. And a lot of, I think it's fair to say, a lot of states didn't jump on that, and they announced NORPS extended that arrangement for another year. Again, state by state had to approve it. Pennsylvania did, and most insurance companies followed suit. There was a window where that option really wasn't available, primarily because the state hadn't agreed to make it available. And now it is available for another year, and it could change again. They might extend it further, but it's hard to say.
So in essence, you, much like this is Jessica, for our own company renewal, we had a renewal January 1st, 2013, and so January 1st, I'll leave it at that. When our renewal arrived, and as an employer we made our decision about renewal, there was no grandfather option. It was only an ACA option. And as Chuck pointed out, somewhere along the line of receiving those renewals, the administration decided that they wanted to uphold that if you like your plan, you can keep it, and left that to each state. By the time Pennsylvania decided to allow every insurance company to decide if they wanted to do that or not, those non-ACA renewals were distributed pretty much after people like us, or it sounds like in your situation with the February renewal, you already renewed in the ACA plan. So there is no ability to go back. If you renewed ACA, you're in ACA. If you were an employer maybe for April 1st and forward, you received 2 renewals. You received a grandfather and an ACA option. People like you and like us that were renewing that January, February time frame, we were not offered that. And that was just simply a byproduct of a change in the new law.
The next question. For small employers, when each employee's premium is priced individually, how do employers charge employees for an employee share to avoid penalizing an employee simply because they are older?
Hello, this is Craig Pritz. I'll address this one very carefully. Now, to answer that question, there are ways to do it and there are ways not to do it that can be considered discriminatory. And the truth is your employees, younger and older, are going to have very, very, very different rates, and what results in is the employer contribution is going to leave those younger employees possibly paying less than the older employees. There is some things out there that we can help guide you on ways to do that. As far as the contribution goes from the employer, if you're making that as a dollar amount, under some circumstances that can appear to be discriminatory. If you're doing it as a percentage, that can be less discriminatory, and the thinking behind it is as a percentage, the employer is paying the same percentage for all employees. It just so happens some employees have different rates based on their age. So there are different ways to approach that, and in some ways can be looked at as being discriminatory. The truth is, though, from an employer standpoint, there is no way that's going to make it like the old world. You don't want to combine all the rates and divide them by the number of people and give everybody that flat cost across the board. Those days are gone, unfortunately.
Yeah, as Craig was saying, if you try to create your own composite rates, which is really what the old style rates have been that we've known for eons, you run the risk of really having budget issues. If a younger person leaves and they're replaced by an older person, that is to say, costs go up. So it's constantly floating. We are hopeful that in the future, HHS will look at this and agree a lot of composite rating of some path that gives employers a little bit more security As of right now, we are stuck with the rating by age, by person, by member, versus the old composites. And there really isn't an easy way to get at the answer.
Okay, the last question. Based on what you're seeing, is it accurate to say that because of the mandate to cover all people, that overall premiums will increase and benefits will decrease as compared to what we've been used to in the past, at least for the short term?
I think when you're looking at, that's a very good question. I think it depends upon where you are in the spectrum. Because the law will affect large employers differently than it will affect small employers. Yes, and that effect will be higher costs. In the smaller market, the employer's plans have to include many other things, and as I'm sure it was discussed earlier, than a current plan. So that already increases the cost. The 3-to-1 compression of the rates, meaning the oldest person can't be charged more than 3 times the youngest. Insurance carriers up to now typically use a 6 or 8-to-1 ratio from youngest to oldest. That compression is only going to increase the costs on everybody under 40. So that also fuels these high costs. On the large employer side, there is the risk, there's the pay or play calculation, and a lot of the solutions among being able to qualify and not pay a penalty will involve employers adopting plans with higher deductibles. And there's taxes on both sides to pay. That also keeps the cost going up, even though the deductibles, the co-pays, co-insurance are going to increase as employers decide not to pay this non-deductible tax, do what they need to do to comply with the law. So they all have different factors, but they all end up with the same answer. Yeah, for various different reasons, we see costs increasing and benefits decreasing.
And the original intention with the mandate was to lower costs by getting people on who had not previously been on insurance. So the original intention was to lower the cost by bringing in all the young uninsured people, but so many other factors, it's a very real possibility that costs are increasing for more people than they intended.
Okay, that is the end of our questions. Again, I very much appreciate your time and attention today. I hope you found this to be at least beneficial from an introductory basic information standpoint. We will share with you the presentation and the questions and answers section of today's presentation with you in the coming days. And within the information, you will also find contact information. You're more than welcome to contact us directly. Again, the Health Alliance for Nonprofits number is toll-free, 1-800-273-6709. Call us if you need more guidance, if you have questions that weren't answered, or you need more information. Again, thank you very much, and have a great rest of your day.